afternoon, everyone. Thank you for joining us in today's HPL seminar. For next week, call a few more peers. Every one of you get 3 or 4 more people, and we'll start filling this room back up again. Thank you for joining me. Today it is my pleasure to introduce our speaker, Justin Saini. He is a master's student in biomedical engineering at the McCaig Institute. Justin first received his Bachelor of Science in Mechanical Engineering in 2023 from the University of Saskatchewan. In 2023 then, after his bachelor's, he started a master's in biomedical engineering here at the University of Calgary under the supervision of Dr. Sarah Mansky and Dr. Corinne Roach. He is currently working on his thesis titled Quantifying Changes in Carpal Bone Position Under Load Using Weight-Bearing Computed Tomography, which is also his title for today's talk. When I asked Justin about an interesting fact about himself, he mentioned that he runs a sunset bracket every year on Instagram to determine the best sunset picture of the year. So if you've taken some sunset pictures and you believe they are worthy of being entered in this bracket, please do so. Thank you, Justin, and I'll
Thank you for that introduction. Yeah, I'm open for sunset pictures anytime. So I'll be presenting the first 2/3 or so of my thesis today, quantifying changes in carpal bone position under load using weight-bearing computed tomography. Hopefully I'll make you guys experts on hand and wrist by the end of this 25 or so minute talk. So this project is looking at the scapholunate interosseous ligament, which is the ligament between the scaphoid and lunate bones at the base of your hand. So it's situated between those pads of fat at the base of your hand. Similar to how the ACL is considered the primary stabilizer of the knee, the scapholunate interosseous ligament is considered the primary stabilizer of the wrist and the scapholunate joint, as it provides stability in response to mechanical stimuli and during wrist motion. It's the most commonly injured wrist ligament, often resulting from a fall in an outstretched hand with a large amount of stress placed on the wrist. So just looking at this a little bit further to help visualize it. So this is the view as if you're looking at the palm of your right hand. And so these scapholunate ligament injuries will influence the position of these bones as they articulate with one another during motion of the wrist. A tear of the scapholunate ligament will lead to abnormal load transfer and joint biomechanics within the wrist, as the scaphoid and lunate are no longer linked in their motion. So just to help with understanding carpal bone motion, I still struggle with it sometimes. So here's a little bit of a visual to help understand that. So if you stick your hand out right in front of you, kind of like there's a clock aligned along your wrist. So if you move your wrist up, that's towards extension, wrist down, flexion. So hopefully this will help visualize it. I'll be talking about it a little bit throughout the speech. So we can divide our understanding of carpal biomechanics into kinematics, which define how the carpal bones move, and then kinetics, which just define how the carpus regulates load transmission and the balances of forces. The scaphoid and lunate will generally rotate as a unit and reflect the global motion of the wrist. So if you extend your wrist, the scaphoid and lunate will extend as well. Then similarly, flexion, it's going to flex. The scaphoid is generally seen as a link between the distal row of bones and the proximal row of bones and the radius, and it is driven into a position of flexion towards the palm when there's no motion or force applied to the hand, and that's caused by its ligament connection to the trapezoid trapezium at the base of your thumb. And so this flexion moment arm, in combination with an extension moment caused from the triquetrum, so on the right-hand side of the screen here, will help maintain normal alignment of the lunate. So if you're looking at the screen here, this ligament here is your scapholunate interosseous ligament, and it's your lunal triquetral ligament, and it helps maintain normal load transfer with balancing moment arms. And then when we look at the when the scapholunate interosseous ligament is torn, along with attenuation of secondary stabilizing ligaments, that means that the scaphoid and lunate are no longer linked in their motion. This tear often occurs in the dorsal component of the scapholunate ligament and is the thickest component of the ligament and provides the most stability to those bones. And so this lack of tether force between the scaphoid and lunate causes scaphoid rotary subluxation, and that's characterized by the following movements. So first off, we have the scaphoid is driven into a flexed and pronated position, and then it will also shift dorsally and radially. And this leads to abnormal load transfer. So when we look at that kinetic side of biomechanics, due to incongruity at that radioscaphoid surface, and as the scaphoid and lunate are no longer linked in their motion, this causes the lunate to turn into an abnormally extended position, as there is no longer that opposing flexion moment from the scaphoid. And so therefore that extension moment that's caused by the triquetrum will, by the ulnar side of the hand, will rotate that lunate into extension. And so there is a well-established pathway for these injuries, from that initial insult or injury of the wrist that's followed by carpal instability, and then eventually wrist osteoarthritis. So in these stage 1 injuries here, hallmark typical of these injuries is pain in load-bearing positions. So particularly when that wrist is in extension, you apply a load to it. The cycle is pain with performing simple tasks like doing push-ups or pushing open doors. But the etiology of this pain is not well understood. During this stage of injury, there are no abnormalities that can be seen on radiographs. And then over time, this will progress to a chronic injury. There's no change that can be observed on a standard radiograph, but there are abnormal changes in scaphoid and lunate position seen in stress radiographs. So on the screen here is a pencil grip radiograph, and you see there's a bit of a gap between the scaphoid and lunate there on your right hand. And then lastly, we have static chronic injuries where there's significant widening seen between the scaphoid and lunate on a standard radiograph, and those two bones are no longer linked in their motion. But why do we care about this injury in particular? The end stage of this injury is scapholunate advanced collapse, better known as slack wrist, and that's the most common form of wrist osteoarthritis. It accounts for over 55% of wrist arthritis cases. And after the ligament is torn, that scaphoid begins to flex, as I mentioned, and shift away from the lunate. So that scaphoid, that bone at the base of your thumb, begins to tilt towards the palm of your hand. And this will cause articular wear to begin to develop at the tip of the radial stylus, that bone that runs along your forearm. And that's the edge of the articulation on the left-hand side of the screen here. And over time, that scaphoid will continue to flex and shift towards the radius, and more cartilage degeneration will occur. And then this cartilage begins to wear throughout the wrist, and it continues to the capital lunate joint towards that palm of your hand. And it continues to progress across the wrist as the disease becomes more advanced. In an ideal world, this progression can be slowed with surgical interventions, but intervening in a timely and effective manner has proven tricky. So this is just kind of a look at some of the imaging techniques that we can use both to diagnose scapholunate ligament injuries, as well as just to study the position of carpal bones. So I already mentioned the two on the left-hand side, but radiographs and stress radiographs are used to detect that gap in the scaphoid and the lunate. And then we can also use CT more in a research setting to understand how the carpal bones move in 3D. These modalities are valuable in studying carpal kinematics and understanding carpal bone position. However, they do face limitations. So radiographs, I'm sure you can tell, they're 3D projections. So you can't always capture the 3D out of plane rotations that may occur and those complex shapes of the carpal bones. And then CT does provide a 3D imaging option. However, it's difficult to image the wrist in functionally load-bearing positions. But luckily, we do have a new imaging modality that can improve upon these limitations. So we can use weight-bearing computed tomography, which is a new form of cone beam CT that can visualize the extremities under load. This is often used to study the foot, ankle, and knee to understand how different pathologies affect alignment of the bones in the lower extremity. So we can use it to look at hindfoot alignment, joint base narrowing, and general instability in pathologies where it may not be easily identified in those unloaded cases. So that's standard CT scan where you're lying down. To date, there have been no studies evaluating in vivo carpal biomechanics in these load-bearing positions, despite pain under load being a common symptom of these injuries. So this work is aiming to address that gap. So that leads me to the main objective of my work, which is to determine the utility of weight-bearing CT to study in vivo carpal alignment and contact biomechanics. So those are just two different measurements that we can use to understand how the carpal bones move with response to load. So to accomplish this task, my work is divided into two specific aims at this stage. So first off, developing an automated pipeline to obtain 3D carpal alignment measurements from weight-bearing CT scans. And then secondly, measuring how carpal alignment and contact biomechanics vary under load, both in healthy wrists and injured wrists. So to accomplish these specific aims, we use the following imaging protocol. So those 10 individuals with an intact scapholunate ligament, so healthy controls, and then 10 individuals who had stage 2, so those chronic injuries that I mentioned earlier, injuries in one of their hands. Each participant underwent 3 scans in our weight-bearing CT scanner. So on the top of the screen here, you can see it's an unloaded scan where the hand is just laying on the CT gantry. And then on the bottom row, there's 2 load-bearing positions. So on the left-hand side, the participant is holding on 2 push-up bars. And on the right-hand side, those hands are in full extension. And then their legs are supported on a massage table. The reason that we chose these 2 positions in particular is that people with these injuries tend to do, when they're doing push-ups, they tend to prefer using those push-up bars. It helps it's been hypothesized that it maintains more of a neutral alignment in the hands as opposed to extension, where that pain is often felt on the dorsal side of your hand. So just to help visualize this again, here's some CT scans. So on that bottom row here, you see that push-up bar position where they're gripping onto a plastic push-up bar. And then on the right-hand side, that wrist is an extension. So it's just a quick look at the segmentation technique that we use to develop 3D bone models. So this process did require some manual adjustments after the connected component analysis. And that's both through the narrow bone widths and the carpal bones, as well as some of the motion artifact that did occur in some of those load-bearing positions. So first off, the first aim of my project was developing that automated pipeline to obtain carpal alignment measurements. So I've been talking about it a lot, but carpal alignment helps to define the distances and angles between bones and are used on radiographs to look for signs of instability. And as we go through, I'll kind of describe more of these in a bit more detail. But the current standard for these measurements is to manually annotate 2D radiographs or 2D CT slices. So these examples on the screen here were done by Dr. Brody Ritchie, who's an orthopedic resident, and then they're subsequently verified by a group of orthopedic surgeons at the South Health campus. As you may be able to tell, or maybe not be able to tell, this is a very time-intensive process, and studies have shown that even slight changes in wrist position will affect measurement reproducibility, which highlights the need for an automated method that can obtain these measurements. So to develop that automated pipeline, I had to figure out ways that I could identify specific anatomic landmarks on both the radius and the carpal bones that could be used to define these angles and distances. So to accomplish this, I developed custom Python scripts that can calculate the principal axes of inertia and the principal curvatures of the bone. So just zooming in here, we can see, so I use specific relationships between these principal axes and general curvature patterns to identify specific points of the bones. And then just a quick look here at the curvature patterns as well. So this is just an example of the 3D automated measurement that I took. So here is a scaphoid illuminate angle, and that mimics a 2D measurement. And an increased scaphoid illuminate angle is one of the telltale signs of a scaphoid illuminate ligament tear. As I mentioned earlier, that scaphoid will turn into flexion with that injury. So we get the axes of the scaphoid illuminate here. So that's denoted by those red lines that you can see on the screen. So just a look at the measurement comparisons between groups. So just quickly orient you on this graph here. The x-axis represents the 2D manual measurements, and then the y-axis represents those 3D measurements that were taken by my automated pipeline. So that diagonal line would indicate the 2D and 3D measurements measure the exact same value. So for points below the line, it indicates that 2D measurements were an overestimation of what was found in 3D. And then above the line indicates an underestimation here. So on the graph here, we see that the scaphoid illuminate angle was generally overestimated by the 2D measurements. So moving forward, we see, this is the radioscaphoid angle, which is the angle between your forearm, so that radius bone, and the scaphoid, and once again is used to observe that increased flexion with this injury. And we see an opposite relationship to what we saw with that scaphoid illuminate angle, is that most of these points are lying above that diagonal line, which means that that 3D measurement overestimated. Then we see a similar trend here in the radial illuminate angle, which defines the amount of extension in the illuminate bone with respect to your radius, and that's another telltale sign of the scaphoid illuminate ligament tear. Then moving forward, we can look at the capitate radius index, which defines the shortest distance between the capitate and the radius, as the capitate will descend towards the radius after the injury occurs. And we see the 2D measurements generally overestimated the actual distance between bones. And that's to be expected, as that 3D automated measurement will automatically be able to detect that shortest distance between bones, or that manual technique requires some interpretation as to what that shortest distance may be. Then similarly, we see the scaphoid illuminate interval here, which is defined by the distance between the midpoints of the illuminate and the scaphoid. So on that top right hand of your screen here, it's taken at that center point of that articulation. And once again, we see that the 2D measurements tended to overestimate for the similar reasons that we saw earlier. Then lastly, we can look at dorsal scaphoid translation here, which detects when that scaphoid has shifted past the back of the dorsal rim of your radius, so that back of your hand. And that's one of those signs of increased scaphoid flexion that we talked about earlier with that scaphoid rotary subluxation. Admittedly, there isn't much of an observable trend here. And that's likely the fact that this is a relatively new measurement in the wrist diagnostic world, and it's not always easy to detect on a CT scan. And then if the scaphoid is not shifted dorsal to the radius, it's reported as 0. So on the screen here, there's about 30 to 40 points at 0, 0 on that bottom left-hand side of that graph. So just what can we take from this? Just to summarize. So first, we see that the 2D scaphoid angles were greater than what we found in the 3D automated measurements. And this can be due to the fact that the 3D technique can better detect the rotation of the scaphoid and illuminate that may not be readily noticeable on a CT scan, which does rely on those single CT slices. And this means that while a flexion and extension can be seen in 2D, the degree of pronation and supination, so that turning of the wrist, may not be as easily seen, and that could cause that angle measurement to decrease like we see on the screen here. And we saw an opposite trend with those radius angle measurements, as a 2D measurement tended to underestimate what was found in 3D, and that could be just due to improvements that we get with that 3D automated measurement, where the radial axis is found by getting that best fit line through the center, through the radius axis, and that may cause more of a dorsal tilt in 3D compared to 2D, which is why we see that overestimation in our 3D measurements. So now moving on to the second piece of this project, which aims to understand more about how the bones move under load. So just oriented to this graph here, the 3 positions are aligned along the bottom of the screen here. Teal represents healthy individuals, and the gold represents the injured individuals. And the normal lines, it's a little bit hard to see, but there's dotted gray lines there, and that represents the normal range for a healthy individual. And that, but it should be noted that that's for a 2D unloaded scan. And we see the scaphoidal angle is significantly greater in the injured wrists than the two weight-bearing positions. And that's because that scaphoid will extend towards the lunate with weight-bearing, and that's what we see there. And then we see significant differences in the injured wrist, and that there is more flexion that we will observe there. Interestingly, differences were less noticeable in the load-bearing positions, indicating that the alignment of these two bones was a bit more straight in those load-bearing positions. Now moving on, these are the axes defined with respect to the radius, so along your forearm. So the radioscaphoid angle is on the left-hand side, radiolunate is on the right-hand side. And once again, we see significant differences with respect to that unloaded position. So the decrease that we see on the left-hand side suggests that that scaphoid is extending with load, which is consistent with what we saw on the previous slide with that scapholunate angle. The lunate also begins to extend under load, and that the largest amount of extension is seen in those load-bearing positions. So you see that opposite occurring on the right-hand side here, and that means that there's more extension. And then the only difference that we saw between groups was in that unloaded radiolunate articulation, where that lunate is in more of an extended position with the injury. And then here, just look at the distance-based measurements. So a capitate radius index, which defines that shortest distance between two bones. And so it does decrease with the application of load, and that is to be expected as that compressive load will decrease the distance between the radius and the carpal bones. And then interestingly, the scapholunate interval was consistently large in the injured individuals, and there was no observable differences between positions. As I mentioned, it was consistently large in those injured wrists, and so that including those load-bearing positions, which suggests that this may be more of a static deformity as opposed to the bones shifting further apart when the load is applied to the wrist. And then just looking at dorsal scaphoid translation here, we see that the scaphoid shifts dorsally in the injured wrist, so with those gold bars, indicating that it is flexing in these positions. And then as more load is applied to the wrist, the amount of dorsal scaphoid translation begins to decrease as the scaphoid is moving into more of an extended position. However, it's still evident. So that's why you might experience pain on that dorsal side of your hand as there is a bit of a load applied to the back of your wrist. And then the only differences we saw here was in that neutral position where that scaphoid is more flexed and shifted dorsally to the radius. So just to sum that all up, we saw increased scaphoid flexion with that scapholunate angle across all positions in the injured wrist, in both the unloaded and weight-bearing positions. And we can see that on the right-hand side of the screen here, that scaphoid tipping towards the palm of your hand. And interestingly, that scapholunate interval is consistently large in the injured wrist, and so that may suggest that it is a static deformity. And then compared to the unloaded hand, like we see on the screen here, we notice that in the weight-bearing positions that the scaphoid is both extended, and so that's both the component of the position of the wrist as well as the load being applied to the wrist. So just looking at that here, so it's a bit more strictly aligned with that radius. And so we're going to move on to the carpal contact biomechanics side of this project, which helps to better understand that kinetic side that I'll speak about earlier, and then just understanding how the bones move in specific joints. And so for this, we looked at two measurements. So first off is joint contact area, which kind of acts as a surrogate measurement between two articulating surfaces. And then secondly, the joint contact centroid, which is weighted based on contact area and distance with respect to the neighboring bone. And it kind of helps to mimic a center of pressure and understand how the bones translate with respect to one another. So just taking a look at this for the radioscaphoid articulation here. So this heat map here represents all points that are within 2.5 millimeters of that scaphoid bone, and that's measured using a ray tracing algorithm. And then from there, we can get the weighted centroid of that area, and then we can apply that to multiple articulations. So on the left-hand side, there is the radiolunate articulation with that centroid denoted in blue, and the right-hand side is the radioscaphoid. So we're going to take a look at changing contact area with respect to that unloaded neutral position. So just to orient you on this graph here, an increase in contact areas towards the top of that graph, and that suggests that those bones are moving closer or rotating towards one another. And then it decreases below that dotted line at 0, and that suggests that those bone surfaces are moving away from one another. So for the radioscaphoid articulation, we observed differences in loaded extension. There was significantly less contact area in that extension position compared to the other two positions. And then there was also a difference in the response of healthy and injured individuals. So we saw a consistent decrease with the healthy individuals, but then it remained relatively consistent or increased with those injured individuals. And once again, changing contact area for the radiolunate articulation here, we see an opposite trend of an extension. So we saw a greater contact area, which suggests that bone-to-bone distance is decreasing. That's opposite what we saw in the radioscaphoid contact area. And then once again, we saw differences between the healthy and injured individuals. And then just a quick look at the capitate articulations here. We didn't see any significant differences here. We did see a large spread in that response. And that could just be the fact that the capitate will descend to that scapholunate interval with varying degrees of rotation and translation. So a bit more on the kinematic side of this project is needed to fully understand this work here. Then we're gonna move on to shifts in the centroid position here. So first off, we're gonna start with a healthy wrist. So the darker sphere here will represent that mean position of the centroid, and that's across all 10 injured individuals, and that larger sphere denotes its standard deviation. So these are mean positions from the origin of the bone, and it's divided into the radial ulnar distance, the proximal distal distance, and the dorsal palmar distance. So that unloaded position is in red here. And we see a significant shift in the centroid when in extension, if it's shifting radially, and that is consistent with what has been found in previous literature when that hand is in extension. Then moving on to an injured wrist here. So all of these centroids have shifted dorsally and radially compared to the healthy wrist. And that's common behavior with the injury, as that scaphoid is no longer linked to the lunate and will begin to shift apart. The radial lunate centroids on that left-hand side of the screen there is relatively consistent in the injured patients. But then we do see differences in the radial scaphoid centroid. So translating towards that radial styloid to the right-hand side of the screen here, and shifting towards the palm of your hand and when you're using push-up bars. So that's represented by that purple circle on the screen here. So just tying that all together here quickly, we saw there's no significant differences in contact biomechanics between the unloaded and the load-bearing push-up bar position. And that may indicate that this position helps maintain a bit more of a normal load transfer and alignment. And there is some interesting behavior that we did observe in that load-bearing extension position. So we saw a decrease in radial scaphoid contact area with healthy wrists, which suggests that that bone is rotating or translating away when we put that hand in load-bearing extension. And then we saw an increase with the injury. And so it suggests that radial scaphoid is shifting towards the radial styloid with injury. So on the screen here, you can see it's shifting towards the radial styloid with injury and maybe rotating away in healthy. And then we saw that radial lunate area increase, which means that those bones are moving closer to one another. So just to summarize what I've been talking about here. So first off, I developed an automated pipeline that can automatically measure carpal alignment measurements that are normally limited to manual measurements on 2D radiographs or CT slices. We did see slight differences in measurement techniques, as that 3D technique is better able to measure carpal bone rotations and automatically identify those minimum distances between bones, which helps us understand how bones shift towards one another. Now, for the second specific aim of this project, we saw the scaphoid and lunate both extended in the wavering positions. However, a bit more work is required to determine if it's the effect of the position of the wrist or the load being applied to the wrist. And we saw with our contact biomechanics where that scaphoid is shifting towards the radial styloid with injury, and that is particularly where it does begin to develop with this injury over time. And so just still moving forward. So this was the first 2/3 of my thesis work. So this is kind of the final third. So firstly, there are kinematics measurements that can be better made to understand how the bones are rotating and translating between positions. As that contact biomechanics work, you need to better understand more so the bone surfaces. We can compare all these results to individuals that have undergone reconstructive scaphoid surgery. And that aims to restore healthy kinematics of the carpal bones. So on the screen here is an example of a RASL procedure, or reduction association of the scaphoid and lunate. We've had 10 individuals that have come in that have undergone this surgery and where they have that screw inserted between their bones. So we'll compare our results to see which group is behaving more like. And then lastly, we can compare that contralateral healthy wrist of the injured individuals to see if there's differences in how these patients load their wrist with injury. Just take a moment to acknowledge all of my wonderful lab members, as well as all of my funding sources that have helped me with this research. At this point, I'm happy to take any questions.
Like to start us off?
I'll start. Thank you, Justin, and thank you for your brevity. 25 minutes, that's the new record in this room. Okay, so bear with me on this question. So when you have the proximity maps, you were showing percent changes in the proximity map. So I'm assuming you're comparing it to the neutral condition.
Yeah, that's correct.
Okay, so when you report the angles and before you did the proximity maps and you reported the angles, you showed like the biggest differences between injured and not injured were in the neutral condition.
Yeah.
So presumably I don't know if this is a fair question or the right question, but is it fair to say that the big differences in the proximity maps are because of the orientation of the bones in the neutral position and not necessarily because of their orientation in the final loading position? Does that make sense?
I think so. Can you just summarize that? If you want, like.
All right, so I'm thinking you big angle changes, in the neutral condition,
Yeah,
not as big of angle changes in the loaded condition.
okay, yeah,
And then I'm assuming that the proximity maps in some way, shape, or form change with the angles and things like that, but I could be wrong, it could be overloaded. So I guess the question is, are the changes that you observed in proximity maps between injured and non-injured, are those due to primarily to differences in the orientation of the bones in the unloaded condition? Or are they due to differences in the orientation of the bones in the loaded condition?
it's a good question. I think it's probably due to the changes in rotation in those load bearing positions.
In the load bearing?
Yeah,
Okay, okay. That's good, because my other question was gonna be if it's due to the neutral condition, like why do they have pain in these loaded conditions?
yeah, so that's a good example, that's a good question. So I think contact area numbers in themselves, and those changes in respect to contact area don't tell the full story. I think what would be more important, and I'm getting there, so I haven't quite got there yet with my work, but I think would be looking for specific locations where that proximity is decreasing in specific areas. So for example, when we go from the neutral wrist to extension, we would expect to see more like an impingement almost on the backhand side of the wrist, because people do experience dorsal pain. And so looking at that change in contact area in specific locations, I think that would be more interesting in understanding how that pain is occurring when we're in extension. If that makes sense.
Yeah, it does. And then I have some methods questions.
Yep.
You talked about defining the coordinate systems of the bones using the principal inertial axes, which makes sense to me. And then you said, and you use the curvature of the bone to find these landmarks.
Yeah.
Can you explain that a little bit more?
Yeah, so it's just, that's just to account for like slight change in morphology of the bone and making sure that it's going to be consistent across all individuals. So for example, in the scaphoid axis here, I can bring that back up here.
Yeah, and maybe talk a little bit about how you would define a coordinate system for such a round bone like that. Because I guess some people have said you use these landmarks, like surgeons have said you should do this, or.
Yeah, so all of these measurements are replicating what they do in 2D. So it's the measurements that Brody took, that orthopedic surgeon. So I'm doing my best to mimic those measurements on the 3D measurements here. And so the reasons why I took the account for that principal curvature as well is just so when you take just the coordinates or the principal coordinate, the principal axis of inertia here, there's going to be slight differences in where that landmark would be just based on slight difference in the curvature of the bones. And so I'm taking essentially the local maximum of curvature to make sure that it's consistent across all individuals with morphology, because it's good, like the difference, like if it's.
So do you look at the principal axes and then you kind of do a little local search based on
Essentially,
curvature?
yeah, it's just a bit of a refinement to make sure that it's consistent across everybody.
Okay,
Yeah.
got it. And then the 2D measurements that you compared your 3D measurements to, were those 2D measurements based on the weight-bearing CT scans, or were they they were?
Yeah, they were.
So
Yeah.
what do? You do a projection to mimic what
No.
an X-ray would look like?
So you scroll through CT slices and you find so you're going to be looking for specific anatomical landmarks as you're going through these CT slices. The gold standard is doing it on a radiograph where it is just like a maximum projection. But for this, just make sure that the wrist was in the same position. We use those CT slices.
Yeah.
So.
Okay. Last question. I'll just keep the floor until somebody else. What about differences in these measurements between contralateral limbs of the healthy person? So just regular asymmetry in healthy.
Yeah, so that's going to be another one of my next steps. We don't have a contralateral in the unloaded scan, but we do have it in the load bearing position. So I'll definitely will be looking at that just to see if there's differences between how you load. I think that's a very interesting direction moving forward for sure. So.
Okay, one more quick.
Yeah.
When you do put when you put the patients in the loaded positions, are they quite uncomfortable? Like, do they say, I can't do this, I don't want to do this?
For the healthy individuals didn't have many problems. I wasn't here for all the data collections, but from what I understand, there wasn't any problems. Some of the injured individuals did have an issue with that extension position. So we did have one individual that couldn't do it at all because he was just in too much pain when he was in extension. And then for the people that were injured that still were able to get a good amount of extension, we put like a foam pad underneath their hand just to make sure that they weren't like in a lot of pain as they were going through that scan. It's about a 30-second scan, so it's not too long, and they generally were able to get through it. So.
Great, thanks.
Adam nodding, I felt like he took away all of his
That's what I was
questions.
trying to do.
I just crossed out a few.
I'm hoping you still ask.
Piggybacking on that last question, were there increased motion artifact in some of the injured folks? Are you able to quantify that at all?
I wasn't able to quantify it, but just, from the amount of manual measurements, I have to say, I'd say it was about the same across both groups. And so in the load bearing, it was a bit more of just like moving your forearms a little bit. And so that would affect how I measure the radius. So it did require a bit of manual, adjustments, those segmentation, but it was pretty consistent, I'd say, across both groups.
So overall, you're not really too worried about the viability of weight bearing CT for these individuals, like pain wise?
I don't think so. Like, I think once we can understand that hopefully get people in a level of extension that they're comfortable with. So whether that be maybe in the future, putting it more of a vertical position and pushing up against the wall and seeing if that's a bit more comfortable for them. But for the most part, the fact that they were able to do it with that foam pad, I think there is a bit of viability in using this as a tool for weight bearing CT.
And then I know you've been asked this question before, but I forget your answer. What do you think people are loading one hand more than the other for injured?
I'd say for the injured, there's probably is a bit of differences. And so I think moving forward, a future direction of this project would definitely be to like incorporate a force plate or something just to see if there's consistency across both hands where they're applying their loads, whether that be on like the palm of their hand or more towards their fingers. I think that'd be a really interesting thing to look at moving forward for sure.
And then last question. Do you think that the time it takes for the CT scan to be performed and for your pipeline to be inactive is more or less than the time it takes to do the gold standard 2D radiograph and then have an individual resident, say, perform the manual measures?
I'd say for the unloaded scans, it's definitely quicker just because there was less manual adjustments required. In the load bearing, there was a bit more. So right now that is kind of the bottleneck in the process, is that it is taking a bit longer with those manual adjustments. So hopefully in the future, someone out there could create an automatic segmentation that would definitely speed up the process. But right now it is probably, I'd say, a little bit longer. So, yeah.
While we're waiting for other reservoir.
Thanks for your presentation. How do you calculate contacts like that, bottom jack contact?
So it's a surrogate measurement for cartilage thickness. So I'll just go back to that slide here. So we take all points that are within 2.5 millimeters of one another. So we use a ray tracing algorithm. So on these 3D meshes, we take the normal of each vertex of the mesh, and then it's going to essentially ray tracing. And so it's going to identify the closest point on the mesh that's closest to it. And it's everything within 2.5 millimeters. And that's been established in literature. That's just a value that can encapsulate that articulating surface that we look at. So it's definitely a surrogate measurement. And it's not like it's a cadaveric study where we can get actual contact area, but it is kind of the best approach for an in vivo technique here.
And is there too much variability between objects?
I don't think so. Like it's generally pretty consistent. Like 2.5 millimeters is a bit of an overestimation of that cartilage thickness between bones, but it just kind of helps to encapsulate where that bone is going to be rotating. So for example, on this one, the scaphoid helmet is rotating with the radius, and it's able to cover that. So it's kind of an estimation, but it is not a lot of variability, I'd say, across participants. It's going to be for the healthy individuals. Everyone will be within that 2.5 millimeter threshold for the most part. So.
If you have some comparison between 2D and 3D, so which one is the gold standard?
So the 2D is currently the gold standard. So the 2D measurements is what the orthopedic resident took, and so that's just manually annotating the CT slices.
In your conclusion, you said that 3D measurements are more accurate. Something like that.
I don't know if more accurate. I don't know if more accurate is probably not the best way to phrase that. I think it just helps to understand all rotations of the bone a little bit better than a CT scan with those 2D measurements, because we can better appreciate the pronation and supination that's occurring with those bones. So I don't know if more accurate is better. I probably should have said that. I think it just helps us to better understand the full 3D rotations of those bones as compared to 2D. I think that's probably a better way that I should phrase that.
Would you say it's like more reliable? Sorry.
Yeah, it's more reliable, more reproducible. So like if I were to do those 2D measurements, if that's certain to do those measurements, there's going to be variability between those people that are taking those readings. So the fact that we can have an automated method that can automatically get those measurements is definitely one of the big benefits of this, the automated pipeline.
We have a question from Benno and then after.
So you said that the 2D overestimates 3D measurement,
Mhm.
and for other ones, the opposite.
Yeah,
Now, that means you know the true result.
sorry,
You know the true result.
yeah,
Why don't you use that
sorry,
true result?
oh, the true result, yeah, so one of the reasons that we don't use those 2D or one of the issues with the 2D measurements right now is that it's slight adjustments in wrist position. So if you're in 10 degrees of ulnar deviation or 10 degrees of radial deviation, there's going to be limits the reproducibility of those measurements. So it's sometimes difficult to identify those anatomic landmarks, which is why we do want to get that 3D measurement that can automatically detect those points.
So I think so are the 2D measurements then overestimating compared to what, the 3D?
The
or-
3D, the
Right.
measurements taken with 3D type one,
Right,
yeah.
so the true measurement of.
So it's not the true measurement that you compare it to.
No, yes, it is. So the 2D is what's taken on those 2D CT slices. So that is that true measurement that we're getting. So that's gonna give us that flexion extension of for example, so from this one, it's gonna give us a flexion and extension of the scaphoid illuminate.
So I guess would you then say that because the 2D is the true measurement or the gold standard, wouldn't you then say that the 3D underestimates your true measurement?
I think we need to define the difference between true and gold standard,
Yeah,
Right,
right?
I agree, yeah.
And so I think in this case, if you say 2D overestimates 3D, you're assuming that the 3D is the true measurement, even though the 2D is the gold
Yeah.
standard.
Exactly.
Gold standard because it's used more.
it's just the current approach that all surgeons will use for diagnostics. So yeah, I guess flipping that, so I guess 3D underestimates 2D would be another way of saying that for sure, yeah.
I like it this way.
Yeah,
Because the 3D measurement is
The
the
3D 's
true measurement.
yeah, it's
Even though it
automated,
might
so
not be the
it's,
gold standard.
yeah. So the reason I phrase it like that is because it's gonna be automated and automated, it's gonna be able to tell us like the full degree of pronation, supination, flexion, extension. So that's why I phrase it as that, but it is the same, similar idea is that 3D is underestimating 2D. It's the same lingo, I guess, but
That answer your question, madam?
Yeah, but I still don't understand it.
I think Aaron had a question and then I'll come back to you, Brent.
Yeah. If you had, let's say just elbow down from, I don't know, cadaver,
Yeah.
you skinned it, would you be able to measure the distances between the carpal bones manually?
so you can use like pressure film, and that has been a technique that has been used in cadaveric testing, so you can see where those locations are within a certain distance. So,
So why would you validate in the cadaver model first and then move into this?
so I personally didn't do it, but there has been tests that have shown, like in whether that be in flexion extension, there has been tests that have validated the contact area measurements between the cadaveric and an in vivo.
In 2D and 3D?
And just in 3D, yes. So those contact area measurements can only be done in 3D.
Okay, and it's just as accurate?
Yeah,
Okay.
yeah.
Brent, you had a question?
I had a question. Did you ever look at the angle? This is a personal selfish question. I used to do a lot of modeling of the distal radius. And I based all of my assumptions on the rotation of the scaphoid and the lunate relative to the radius on cadaveric studies. And, for every, 30 degrees of extension of the wrist, the lunates rotated 40 degrees, the scaphoids rotated 60 degrees. Have you ever compared any of the rotations that you get? Have you ever looked at how those bones are rotating relative to the radius?
That's right now, that's what I have with the radio scaphoid and radio lunate angles, but for the actual like degrees of rotation itself, the common approach is to normalize to the third metacarpal. And so that will help us understand that, position of the wrist, and so understanding how much the lunate is rotating, overall. And so that's kind of like our way to normalize it is, standardize the third metacarpal.
So I'm assuming that those cadaveric studies that I used to rely so heavily on were not in a weight bearing position. They were probably just doing this.
Yeah, just flexion extension typically, yeah. There has been a couple studies in recent years that have done some load bearing or mimicking load bearing, but it's generally been limited to just flexion extension and then ulnar deviation, radial deviation.
Okay.
I think you had a question back there?
Oh, I think you back on videos, but, my question was, do you think that, the carpal position changes are related because, CT maps would they be the initial comments for prognostic biomarkers and early degeneration or risk on doing those?
So there has been studies that have shown those contact area measurements can help to identify signs of instability, even when a radiograph looks normal. Those have been pretty small case studies though. In terms of diagnostics, I think what's still most valuable is going to be those unloaded measurements here. I think for the load bearing measurements, it's going to be more valuable in the surgical planning aspect side of things. So,
Can I kind of piggyback off that?
Yeah.
So with your contact biomechanics, it's slated on the radius, but I'm wondering if the actual area of contact is moving around on the scaphoid and the lunate, and have you looked at that?
that's going to be part of my kinematics work, is looking at how that centroid is shifting on the scaphoid, because that'll help us better appreciate if it's in the flexion extension direction, pronation, supination, or radial deviation, ulnar deviation. So that will help us understand a bit more about how that bone is rotating with when you apply load and through different positions. So yeah,
Yeah, I wonder if that ties to like really.
yeah, I think it would for sure. Yeah.
Based on the stuff that you've done so far in your cases, would you then say, I'm assuming right now in the gold standard, it's a like non-load bearing, neutral position and 2D scan. So would you say based on your work that the load bearing is an important aspect to add to those scans to understand what's going on with these?
I think from a diagnostic standpoint, it doesn't add as much value, I'd say, because like we saw those significant differences between the healthy and injured individuals with mostly in those unloaded positions. I think, like I mentioned, I think it'll be more important with in surgical planning. So for example, that screw that you saw inserted between the two bones, I think it's gonna be more important in that aspect and understanding how the bones are gonna shift when you apply a load to it. So I don't want to I could really get into the depths of this, but for the kind of the Spark Notes version is that if we can better understand the rotation of the bones, that'll help us to maintain a bit more of a normal or like healthy kinematics, as opposed to just reducing that interval, which is what we currently have with just a screw. So if we can account for that rotation more of the bones, that would be, I'd say, allow for a more effective surgical technique.
And kind of off of Brent's first question about the changes being more, bigger in the unloaded condition versus the loaded ones.
Yeah.
Don't you think that the fact that the injured population is so significantly different in the neutral position, but then very similar to the uninjured one and the loaded condition?
Yeah.
But that still tells you that, the difference of them going from their neutral, like,
Neutral to the load bearing, yeah.
that is a much larger shift than what the uninjured population.
Yeah, I think I haven't actually looked at the specific shifts between injured and other than just like the differences between the like unloaded and load bearing, but I think that would be interesting to see that degree of shift between that and see if there's any value in looking at that and see if that tells us anything about the amount of rotation and translation that we get with those bones. So yeah.
And then last question. With your 3D stuff and your model, you are introducing obviously a more efficient way of doing things, and you're getting a 3D measurement, which as Brent said, maybe 2 measurement. But are there certain limitations or challenges you're adding with this compared to the gold standard we have right now?
It definitely took a long time to find an efficient or consistent across all individuals. It definitely took time to find a consistent technique that would identify the same anatomic landmarks across all those individuals. But I think now that I've gone through that work, it's not going to be as tricky. I think for sure this is something that would work most effectively on injured individuals before you see like osteophyte generation with those like post-arthritis patients. So I think that would require some adjustments, but for now I'd say it's a relatively it's a reproducible technique, so not a lot of problems with that. So
Yeah, the question's called.
I'm curious from a methodological standpoint, how did you get them weight bearing in the weight bearing CT? Was it oriented? I would have missed it.
So it's just here. So their legs were supported by a massage table. So it was like, if I had to approximate, it would be like about 40 to 50% body weight, but so the legs are aligned along the massage table, and then we just got them to grab one of those push-up bars or an extension.
And how consistent do you think you're able to get the loading between like the injured clinical population and the healthy population? I wonder if like they naturally try and offset a little bit more. weight.
Yeah, I think that's definitely something to be interested in looking at moving forward, is like implementing a force plate in some way to see if there is variation in how they apply load, and then look at the repeatability. So if we put them in a scanner 4 times, how consistent it's gonna be across all those trials, but haven't quite got there yet. But I think like this is more of an exploratory analysis to just understand how those bones shift under load, but definitely moving forward to standardize it. I think understanding how you load on your wrists across both hands is a very important next step to take.
So was there any like consistency tried?
So we
Like, the cable
instructed them to put as much weight as they could comfortably while maintaining, like normal alignment in their hand and their shoulder and their elbow. But, that's as far as we were able to take it at this stage. Yeah.
Any last questions for Justin before we thank him for the talk? Right.